Hi folks, welcome back to our functional anatomy videos, and today we're going to start looking at the quadricep group. So we've started on the pelvis, and as the quad's attached to the pelvis, we'll be looking at the quadriceps. And the first one we look at is rectus femoris, which is the first one of 4 quads that we have in our quad group. We're looking at the left quad. This is a male torso or skeleton. Difference is the females are going to have a slightly wider pelvis. Essentially, though, for the rectus femoris, it's going to pretty much be the same. So as a bit of an overall view, so we've got the rec fem. It sits on the anterior part of the leg. And the other 3 quads are going to sit beneath this one. So this is the most superficial quadricep group muscle, if you will. Now, this one's unique. The other 3 muscles, our vastus lateralis, vastus medialis oblique, and our vastus intermedius are all primarily knee extensors, as in like they only really affect the knee joint, whereas the rec fem crosses the hip joint and crosses the knee joint. So it's a multi-joint muscle. So that makes it kind of unique and kind of special. So we're going to talk about it. So let's do the anatomy first. So I'll highlight this bad boy. And as always, we're using complete anatomy, and I highly recommend you get this if you want to go deeper into your anatomy learning. Starting at the origin here, anterior inferior iliac spine and supraacetabular groove of the ilium. So if we kind of scroll in. All right, so this ridge here of the pelvis, this is the iliac spine. And here on the front where it kind of sticks out, this bit there, that's the anterior superior iliac spine. And then it kind of curves around. And then we've got this anterior inferior iliac spine on the ilium. So you've got 2 ridges, the first ridge, and then you drop down onto the second ridge. All right, so there's that part of the tendon goes to there, so on the front of the pelvis. And then just below it here, this section here is going to be our supra, meaning above, acetabula. So this is the acetabulum here, groove, and this is a groove there, supra, above, acetabular groove. So in there. So it's essentially one tendon, even though it does bifurcate there a little bit. The 2 tendons become one big tendon, goes into the quadricep muscle. So essentially the thing where it's highlighted yellow or where it's white, that's going to be the tendinous aspect of the muscle, and where it joins the red, that's the musculotendinous juncture, both superior and inferior. And just noticing here the fiber direction of the muscle. So remember, when a muscle is going to contract, they're going to slide across each other in the sliding filament theory, and that's going to be creating a pulling action, right? So when the 2 muscle fibers contract, they're going to pull. And so that's either going to create a pulling action on the knee from this direction up, or because it's attached on the pelvis, it's going to have a pulling action coming down. We'll talk a bit more about that in a minute. That's quite important. So then it goes into the patellar tendon or the quadricep tendon, sometimes called the patellar ligament. Wraps around the entire patella, and this tendon becomes continuous with the other 3 quadricep muscles. So it's essentially all one big tendon, and then wraps around that patella, which gives it a bit more leverage, acts as a fulcrum so it can generate more force. And then it's going to attach onto this bony part here on the tibia called the tibial tuberosity. So where we have a tuberosity, it's usually a rough part of the bone. Often it has a slight raise to it, and that's going to be a tendon attachment point. So this big extra bone growth here, that's really adapting to the strong pulling of the tendon on the bone there. And in a condition called Osgood-Schlatters, often as teenagers are growing up, as the muscles are getting stronger and the bone is still forming, that can create a lot of pulling force on that aspect of the bone. And for some teenagers create a lot of knee pain, which typically resolves once the skeletal structure really starts to form and get harder. So it's a growing pain type situation. May require some modification of activity depending on what the person's doing. So that's the quadricep rectus femoris, quadricep there. Action, extends the leg at the knee joint and flexes hip at the hip joint. So we'll look at that in a minute. Innervation, L2, L4. So if I put here on the nerves, there we go. So we have here this blue nerve here. This is the L2, L3, L4 nerve. So you've got 3 levels coming out of L2. So that means it's from the L2 vertebrae and L3 vertebrae. So the level that comes out between. So L2, 3, L3, 4, L4, 5, 1, 2, 3. So the 3 branches that are coming out of the spinal cord comes anteriorly to the front. So things like the psoas is going to be sitting on top of this muscle here. And then it's going to hook around the front of the pubic bone here. And then it kind of innervates into the rectus femoris. And you'll see here there's a big kind of branch where the nerve spreads out. So this area up here particularly, it's quite a sensitive area. And trigger points for the rectus femoris are actually up around these areas too. So this kind of hip crease region, very, very sensitive, lots of important structures in here. You'll often know this this nerve is affected when people have a disc pathology. So they have a, let's say, for example, L3-4 disc pathology. So they might have a bit of a disc protrusion coming out of L3, L4. And if it pinches on the L3-4 nerve root, that can give you this anterior hip pain and also coming down the quad. So people describe the pain coming down the front of the leg into the groin quite deep. So that's a bit of a sign when we're working with folks that they might have a disc pathology and it might be affecting the L2-3 nerve root, particularly if it kind of comes down the front. Let's take the nerves away. Okay. So what else do we want to look at? We'll go back to info. Action, innervation, arterial supply, deep femoral and lateral veins and arteries. So they're going to coming down through here again. So you've got some pretty big arteries through there. Okay, let's have a look at the motion. So we have a muscle that's a 2-joint muscle. So it's knee extensor and a hip flexor. So let's check it out. Let's have a look at knee extension first. Preparing muscle motion. I need my computer working really. I've got a really good computer too. So this is quite a big software program. You do have to be patient. It's very, very good, but it can be kind of clunky, I've noticed. Here we go. All right. So always see it better from the side. Pause here. So this is knee flexion. So when your knee's in bend mode. And good range of movement for your knee is not shown here, but you should be able to get your heel to your butt. So this whole knee will bend all the way back. Okay. So you can sit on your heels and you're in full knee flexion. When I'm working with clients, that's one of the big goals we have when doing any knee rehab is, can you reestablish that full range of movement at the knee joint? So this is only halfway. This is half the knee movement is better than no knee movement, but you can't do a lot with only 90 degrees. So if you look at there, that's 9 degrees. At minimum, we want 145. And then hopefully we can get full range. It depends on the knee problem. One of our big goals with total knee replacements, we're working with people with total knee replacements, is we want to restore this range of movement as much as we can. So the quicker you do get your knee rehab going, and on my experience, the prehab works really effectively as well, the better it will be for the longer term outcomes. So this would then put the muscle on stretch. So if you want to stretch this quad muscle here, you need to, first thing you need to do is flex the knee. All right, so you're going to start to lengthen this tissue out here. Now, when the muscle contracts, it's going to shorten and straighten the knee. So you can see the muscle contracting. It's creating that pulling action we were talking about just previously. And now the knee's in full extension. Okay. And we also want to restore knee full extension. So depending on the injury, sometimes you lose a little bit of extension in the knee. And that's a problem. We want to try to restore as much full range of movement as possible. So that's knee extension. And that moves through into knee flexion. And if that kept going, it'd go heel to bum all the way up. So we want full range of movement at the knee. And then if you're basically sitting heel to bum, that's what we call soft tissue approximation, as in like it's the anatomy that's stopping the range of movement. Either the bones are moved into each other and the structure can't go any further, or there's soft tissue you're actually blocking away and you can't go any further. And that's your full range of movement. You can't move past that. We're trying to restore that. So one of our goals in exercise rehabilitation, we want muscles that are flexible enough, as in like they can lengthen under control to allow the full joint to move through its full range of movement. Okay, so flexibility is a combination of the muscles being able to elongate and then return back to its normal resting position, but also of the ability for the bones, the two joints that make the two bones that make the joints, to move fully through their range of movement in both directions. And if you can achieve that in all your major joints, you'll have a body that moves really well, often be unrestricted and pain-free. That's one of the big goals we're trying to get to. Okay, now if we look at hip flexion, slightly different. So hip flexion now, the muscle action changes. So the knee here is staying at 90 degrees here. So there's no movement, no change in the joint angle here. But now the movement's coming through this joint, the hip joint or the femoral acetabular joint. So if you visualize the quad muscle here attaching onto the ilium, and this one here, that's sartorius, it's showing there. Okay, it's going to pull the leg up or the knee towards the chest type situation. So as it contracts, knee to chest. Go back. So knee up to chest, contracting, 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 contracting. So there's 90-degree hip flexion. You should be able to get your knee or your thigh onto your belly or chest. That would be full hip flexion, around about 145, 150 degrees hip flexion. Okay. Sometimes people will describe like a bit of a blocking or a jamming sensation as they bring the chest towards the knee, or knee towards the chest. And that's often the femur here. This femur, as you keep lifting the knee up, it's going to essentially either get jammed up into, can you see it? Yeah, the femur basically connects to the rim of the acetabulum, and you get like what's called a bony block. But if you move the femur out a little bit into external rotation, a little bit of abduction, you'll clear that and you'll be able to move past that. Everyone's got a different shape in their acetabulum femoral joint or the hip joint. So some people have no problems at all. Other people can get quite jammed and quite pinching, and that can kind of cause some impingement type problems in the pelvis and some labral problems. And there are different kind of forms, what they call cam impingements, that develop as if you keep kind of pinching that part of the hip, the body will respond and grow down more bone, and then you lose more space and it gets more jammed up, and it just sets up a bit of a cycle. So that will be hip flexion. So what can happen is you can get knee extension and hip flexion together. So that's like a straight kick. So imagine you're kicking a soccer ball or a football. So that would be, well, the leg is straight. Or you can have more of a running gait where you've got hip flexion. So you're driving your leg up, knee towards the chest in like a running kind of action. And the knee stays flexed there. So hip flexion is really, really important in the walking or gait. Often people who've got hip issues where they can't flex the hip for pain or restriction, they can't clear their foot as much as that, and they can trip. So we want to be careful that we don't let people trip. So restoring hip flexion is actually a really, really important part of our quadricep training. Now, the key thing to another key thing to kind of keep in mind here is that hip flexion is a combination of the rectus femoris, the adductors, which is why they're shown here. So we've got adductor magnus and longus in here. So that's adductor longus, magnus. We have iliacus, and then we have psoas. We've got 1, 2, 3, 4. We got pectineus there. Is it showing up? Yeah, pectineus, sartorius. So 1, 2, 3, 4, 5, 6, 7. 7 primary hip flexors that are all going to be working together to lift this knee up into hip flexion. Okay. Now, notice how the psoas muscle, which is quite a big one, attaches onto lumbar vertebrae 1, 2, 3, 4, 5. So when you're doing hip flexion or lifting your knee towards your chest, okay, this strong anterior pull here is going to create a pulling movement on the lower back. Okay, and if your core muscles aren't strong enough to maintain the spine in a good position, it can create an excessive flexion or lordosis in the lower back. And if the muscles go particularly tight, it can also then start to anterior tilt your pelvis. So you get this combination of tight hip flexors. You often hear this kind of tight hip flexors. And it's a combination of psoas, iliacus, adductor longus, pectineus, major, sartorius, rectus femoris, and a little bit of TFL here on the side. Tensor fasciae latae are all tight. Okay. Now, depending on the sport you do, if you're a cyclist, I guarantee you're going to be tight in those muscles because cycling is all about hip flexion. If you're a runner, you're going to be tight in these muscles because running is all about hip flexion. So you will definitely have a certain degree of stiffness and tightness in these muscles. So if you are a runner or a cyclist, the goal is not really to get crazy stretchy, but it's just to maintain good tissue length so that the muscles can contract and relax, and with enough strength and stability to maintain joint position and create the movement that we're looking for. And that's what we're trying to achieve with that. So it's a real big balance between the two. The last thing we'll talk about is how to stretch out rectus femoris. So essentially the golden rule when you're trying to stretch a muscle is you just reverse the action. So typically what you'll see in people with stretching the muscle is you want to put the hip into extension, and then you stretch the hip part first, so you just reverse everything. So you bring the femur back into hip flexion. To do that, you'll need to have a strong butt and anterior muscles to maintain neutral pelvis, because as you bring the hip back, it's going to create the pelvis. The pelvis is going to want to tilt forward as you do that. Okay, so you need some anterior core stability and gluteal strength to maintain pelvic neutral. And sometimes you'll even see people try to get you into posterior tilt, help facilitate that stretch as well. But as long as you're in more of a neutral position, you bring your femur back into extension, that'll start to stretch the rec fem fibers. And then you need to put the knee into flexion as well. So you're going to bend the heel up towards your butt. And so you'll see it's often like a kneeling hip flexor stretch. Okay. And then depending on how much stretch you want in this rec fem, then you can do things where you start to put your foot up against the wall. So you're kind of getting a passive knee stretch, and then you get into that kneeling lunge position, and off you go. So you want enough range of movement in here that you can take the leg through both degrees of movement. So you want knee to chest range of movement, and then you also want heel to bum range of movement, and then knee coming behind the leg to stretch out the rectus femoris fibers. Let's go back. So if we've got, and that is models. Anything cool there? See, nothing. No models. Exercises. Let's see if we got any exercises. No, I don't have access to them. Brom. Okay. So that is our rectus femoris, one of the 4 quad muscles. In the next video, we're going to be looking at the other three muscles as a group. So vastus lateralis, the lateral quad muscle, vastus intermedius, the medial quad muscle, and vastus intermedius oblique, which is the kind of the big tear-shaped drop muscle here that you'll see. So we'll see you then. Thanks for watching. Stop being there.